Really, please.
Yeah. Good evening, everyone. I, Dr. Archana Vare, Professor and Head, Department of Ophthalmology, Government Medical College, Chhatrapati Sambhajinagar, and member of Scientific Committee, Maharashtra Ophthalmic Society. Welcome you all for this webinar. And today's webinar, we have two young presenters. The first presenter is Dr. Shivani Bansode. She is a student of Nair Medical College, and she's mentored by Dr. Naina Poddar ma'am, who's the professor and head, Department of Ophthalmology at Nair, and Dr. Salma Tabani. She is also from Nair Medical College. And the second presenter is Dr. Shraddha Kute. She is resident in ophthalmology at HV Desai Eye Hospital, and she is mentored by Dr. Shilpa Sonar Khan, who is the consultant and head of pediatric ophthalmology and strabismus at HV Desai Eye Hospital, Pune. And we have two examiners. The first examiner is Dr. Sunaina Bhatt ma'am. She's the professor at Father Muller Medical College, Mangalore. She's our national examiner. And Dr. Hemalini Samant ma'am, who is the senior consultant at Jaslok Hospital. And she is the director of Acura Sight Eye Clinic and Laser Center. She is our state examiner. So I welcome you all, and I request Dr. Shivani to share her screen and start her presentation. So each presenter will have 10 minutes for presentation, and then there will be 20 minutes question and answer session. So Dr. Shivani, please start your presentation.
Okay. Good evening, everyone.
Adi.
Yes, ma'am.
No, go ahead.
Good evening, everyone. I would like to thank the MOS team and members for giving me this opportunity. I will be presenting a case of 9-year-old male child, resident of Nala Sopara, who was brought by parents to ophthalmology OPD with chief complaints of inward deviation of right eye since childhood, which was non-progressive. There is no history of sudden onset or rapidly progressive deviation, diplopia, fever, or convulsions given by the parents. There is no history of any previous ocular trauma or surgery or any excessive screen time or spectacles used. He is a known case of ventricular septal defect, diagnosed at 2 months of age and was advised observation. Birth history was within normal limit. His developmental milestones were normal. His personal and family history was also not significant. The child was alert and active and oriented to time, place, and person, and was vitally stable. On systemic examination, we had referred the child to the cardiologist for the ventricular septal defect, and there was pansystolic murmur heard. His other systems were normal. The cranial nerves examination was normal. Coming to the ocular examination, there was no facial asymmetry, and the child had 20-degree right head tilt. This is a representative image of how we measured the head tilt in our patient using the help of goniometer. Coming to the vision assessment, the best corrected visual acuity for distance on atropinized refraction for both right and left eye was 6/6 with plus 1.25 spherical, 0.25 cylindrical at 90-degree correction. On sensory evaluation, the Worth 4-dot test for distance showed no separation, and there was gross stereopsis present on the TNO chart. On motor evaluation, we found there was right eye 30-degree esotropia on Hirschberg's test. Cover, uncover, and alternate cover test with glasses showed alternate esotropia with preferred fixation for the left eye. On prism cover test for distance and near showed 60 prism diopters esotropia with glasses, and it was 70 prism diopters in up gaze and 50 prism diopters in down gaze, suggestive of A pattern esotropia. Here is a 9-gaze picture of the child showing limitation in elevation in adduction in right more than left eye. As you can see, -4 in the right eye, -2 in the left eye, along with -1 abduction limitation in both. Anterior segment evaluation was normal. And on fundus examination, there was +3 intorsion in the right eye and +1 intorsion in the left eye. The child was given glasses for a month, but there was no improvement in esotropia with the glasses, so we decided to go further with the surgical management. This is a clip of intraoperative force duction test and exaggerated force duction test which we did in our patient. So this is a force duction test which was performed for the superior rectus, inferior rectus, medial, and the lateral rectus, and it was found to be negative. Then we did the exaggerated force suction test of Guyton. The globe was retropulsed downwards to relax the recti muscle, and it was moved, and you can see some tightness in the superior oblique tendon. So the globe was moved up and inside. We showed tight superior oblique and down and in outside. So the tightness was felt in the superior oblique right more than left. So we came to the provisional diagnosis of alternating non-accommodative esotropia with bilateral Brown syndrome with compound hypermetropic astigmatism, and we planned the patient for bilateral medial rectus recession 6.5 mm along with superior oblique split tendon elongation 8 mm in the right eye and 4 mm in the left eye. This is a surgical video showing right eye superior oblique split tendon elongation. After the force suction test and exaggerated force suction test, superomedial phonics incision, conjunctival phonics incision was made. Superior oblique tendon was hooked and isolated, and it was split longitudinally into two halves. Then, using a 5-0 ethibond suture, we passed the suture in the upper temporal and lower nasal part of the muscle, and the muscle was split into two parts. And it was cut at the suture, and it was joined end to end, as you can see in the clip also and in the image also, to give an effective elongation of about 8 mm. The same procedure was performed in the left eye along with medial rectus recession of 6.5 mm. So there are other procedures also other than superior oblique split tendon elongation, such as superior oblique silicone expander, chicken sutures, but there are increased risk of infection, extrusion of implant, inflammation and scar with the silicone expanders, and post-op adhesions with the chicken sutures. So we preferred for split tendon elongation. So this is a post-op day 1 image of the child showing good alignment. Thank you.
That was a wonderful presentation, Dr. Shivani. And I would like to request Dr. Sunaina ma'am to ask questions to Dr. Shivani. Sunaina ma'am?
Yeah. Okay, that was a very well managed case and quite unique also. Like you had esotropia along with Browns. So, did the parents give any history of like Browns would have been there since birth, right?
Yes, ma'am. But ma'am,
Did
parents
you
didn't
ask?
give history. They just
Hmm.
came with chief complaints that a child has inward deviation since childhood, and they noticed it recently only.
Yeah, so to confirm that it was not there since birth, what can you do? Since the parents have not noticed.
And
So
we
what
can
can you do?
ask for the photographs to see whether it was present since birth or it was recently the child is
So
eyes.
exactly, it is known as a PAT scan. So in fact, even every routine patient, whether you are suspecting something or not, it is always better to ask for serial photographs.
Yes,
The
ma'am.
first year birthday photograph, almost everybody will have. And nowadays with smartphones, they will have photos of almost every month. So that one point I wanted to make. Mm, why did you like, why was the surgical procedure chosen? You said there are many options, right?
Yes, ma'am.
Why was this chosen in this patient?
Ma'am, first we didn't thought of Brown syndrome in our case. We were thinking of a simple esotropia case only, but we had kept all the necessary like backup for the Brown syndrome also. And we chose for superior oblique split tendon elongation because the muscle was thick in our case, as we can see in the force suction test which we performed. And
So
because of
post
that,
traction test, you decided to do that procedure.
sorry, ma'am.
Post traction test, you decided to do that procedure.
Yes, ma'am.
Okay. So how did you assess like how much is the tightness? Now there again it's graded, no?
Yes, ma'am.
Hmm.
Depending upon how much the globe is moved up and inside, like
Yeah, but what we confirm on table is just tightness. So how you decide the grading is based on how much of extraocular movement limitation is there, right?
yes,
In
ma'am,
your 9 gaze photos you mentioned -4.
-4.
Yeah, so that indicates a severe grade, right?
Yes, ma'am.
Okay. Uh, Anybody else would like to comment something?
Emalini ma'am. Ma'am, you are muted.
A very nice case. You mentioned, doctor, that was somewhere in the slides you mentioned that you did an atropenized refraction.
Yes, ma'am.
Okay, so what is atropine?
Cycloplegic and Midriatic.
Correct. So it's less of a Midriatic, it's more of a cycloplegic. So in pediatric practice, what other cycloplegics do you use?
Ma'am, we can use itrop homatropine 0.02% and itrop cyclopentolate 1%.
So in this case, in this particular patient, the squint was alternating. You were saying it's long-standing. It was a constant squint. Did it
Yes.
look like an accommodative esotropia?
Ma'am, it looked like, but on we had prescribed glasses to this child, but he was not improving with the glasses also. Like the squint was constant with the glasses also. So we
Correct.
ruled
But what I'm
that.
trying to tell you is that atropine has to be reserved specifically if you have or doubting an intermittent squint or an accommodative esotropia. This was a constant squint, so there was no need for using atropine. You could have used a shorter acting cycloplegic. So which is a shorter acting cycloplegic?
We can use itrop homide.
Homide is also long acting, which is a short acting, which is available in the OPD.
Itrop tropicacil plus
Tropicacil is a midriatic. Something with C?
cyclopentolate.
Correct, cyclopentolate. Okay, so you can use that as a shorter acting cycloplegic that you could have used in this patient. You may also mention about Wirtz 4-dot test, and you said that the child had suppression. What is the clinical significance of Wirtz 4-dot test?
Ma'am, we can, by the Wirtz 4-dot test, we can see whether the child has a normal retinal correspondence or abnormal retinal correspondence. Also, we
So
can.
correct. So if I was going to tell you that this child has an abnormal retinal correspondence and has a manifest squint, like has an esotropia, and instead of 3 dots or 2 dots, his response would have been, I'm seeing 4 dots. That means 3 of one color and 1 of the other, or 2. Means basically, so what is your interpretation of that then?
Ma'am, because of such long standing, he must have developed extrafoveal or eccentric fixation because of
No, eccentric fixation means poor vision. What I was saying
extrafoveal.
is anomalous retinal correspondence is what I was wanting to know. Okay, and what are the other various patterns? You said this patient had an A pattern. Which are the other various patterns that
We
you
have
know
V
of?
pattern, X pattern, Y pattern,
Very
lambda
good. Very good. And what is the importance of the FDT? What does it help you to differentiate?
FDT helps to differentiate between the restrictive and the paralytic squint. It is
Very good.
positive and restrictive, and
Ex Excellent. And the last question, what are the causes of acquired Browns?
acquired Browns could be iatrogenic. It could be because of rheumatoid arthritis, canine tooth syndrome, or some trauma, trochlear trauma,
Or an
infection.
inflammation of the trochlea, cysticercosis, dog bites, blowout
Canine
fractures.
tooth syndrome.
Okay, excellent. I think she's good, madam.
No, we have to till 8:30 we have to ask her questions and
Oh, you
then
have to keep asking her
Okay,
questions.
I
Okay, then
see.
can you?
Okay. So you mentioned the use of cycloplegics, right?
Yes, ma'am.
So before you administer cycloplegics to your patient, what history will you take? What all will you rule out? And what will you warn the parents?
Ma'am, if we use eye drop cyclopentolate, there are high chances of, in some child, there are CNS depression, or the child may act hyperactive. So we have to make the patient to wait for 1 hour after our examination to look for such hyperactivities or anything, and we have to
No,
monitor
no.
it
If
all
I
this.
make such, so if
Hyperactive?
even in Nair, if you make
Yeah,
patients
fair
wait
enough.
for 1 hour, when your OPD will get over, huh? Poddar madam will say, OPD khatam kyun nahi ho raha hai, bhai? No, you have to basically look for convulsions, and in general, you will not give cyclogel in patients who have CNS disorders or history of epilepsy, etc. But otherwise,
History
most
of
of the times,
epilepsy.
yeah, nothing
Yeah.
happens with cycloplegic. Okay, and if you're giving
So,
atropine, then like madam asked, what instructions will you give?
That the child will see blur for at least 10 to 15 days.
Huh.
He would be able to do his reading and near with stuff.
Correct.
okay, what else?
A fever, if there is any
Correct.
fever, it should come back again and stop the ointment.
So, what instruction will you give the patient when you're giving the atropine?
So
How many
I
days?
ask the parents to put a pea-size ointment 3 times a day for 3 days, and if there is any fever, we will ask the parents to report back
Pea size.
immediately to stop.
Pea size will be a sphere of almost
So you say rice के
5
दाना
mm.
जितना.
Grain.
हाँ हाँ, हम भी वही
हाँ,
बोलते हैं.
rice के दाना जितना you have to
Yeah,
put, not pea
yeah.
size. Pea
As
size
much as
तो
a
हाँ.
pea size तो बहुत हो जाएगा. Okay.
What are, you also mentioned that you did medial rectus recession in this patient, right?
Yes, ma'am.
So could you describe the steps of recession?
Ma'am, we did the
What
medial.
is recession? Recession means weakening or strengthening?
Recession is weakening, ma'am.
Okay, so describe the steps of recession.
Recession.
When we did the conjunctival incision we made, then we hooked the muscle, separated the intermuscular septum. Then we measured 6.5.
Where,
We disinserted the
what are the
muscle.
two types of conjunctival incision?
Fornix based and limbal based.
Okay.
So you must mention that, no?
Yes, ma'am.
Okay, go ahead. What have you
Then
hooked the
we
muscle after that?
hooked the muscle. Then we disinserted it from its original insertion. We measured 6.5 mm on the
But
caliper.
if you disinsert the muscle, it will slip. So will you do something before you disinsert the muscle?
We tied the muscle for 60, sutured it first.
Suture
60.
what? You take stay sutures, you suture it to the sclera. What do you do? You've seen a recession,
So,
then
See, you would have seen the steps. It's important to use certain keywords, which helps us to understand that you have understood. What do we call that suture?
stay suture. You take a stay suture, na? You take
Mm.
you take it on both ends or one end, or what do you do? Doctor?
Dr. Shivani, have you understood the question?
No, she's offline, I think. Shivani has
Offline,
lost
I
her.
think.
Yeah. But Nena Madam, more or less, she knows her stuff well. She's
Actually,
okay.
to be very frank, she has assisted, but I think she's very nervous. She has assisted on lots of cases.
hello.
Okay.
You're back. You're back.
Shivani, you are there, beta?
Yes, ma'am.
Yes. What happened?
Muscle pass.
Yes, tell. You have assisted
Ah.
so many cases. What you do? What is that whip suture? Describe. What do you do
We
with
did
60?
with muscle pass.
Okay, good.
Pass.
Okay, so you've taken your sutures. Then what do you do?
And we have to measure. We measured with 6.5 mm with the help of the caliper, and then
Okay.
and then at behind the insertion point, we have to resuture the muscle back at 6.5 mm.
Okay. And what the 60 vicryl is a single arm suture, is a double arm suture,
Double
it's
arm
round
suture.
bodied.
Double
Okay.
arm.
It's double arm suture. Is it micro cutting edge or is it round bodied?
Oh, cutting end.
Cutting edge, correct. Can you describe the steps of resection?
Resection. And then we did the conjunctival phonic sensation is taken. Then we identified the muscle which is to be resected. Then we hooked the muscle. We separated the intermuscular septum around it. Tenons has to be separated. And then after hooking the muscle, we measured the amount of resection which we have to be performed on the caliper. Then
Let's
we
say 6 millimeters. Let's say on the lateral rectus, you have to do 6 millimeters.
yes. So we measured 6 mm on the millimeters on the caliper. We marked it on the muscle and then we cut it and insert it on its original insertion point.
Okay, good. Great. Very good.
Can you tell me what is spiral of Tilloch?
And spiral of Tilloch is the point where all the recti muscle are inserted. Like it forms an imaginary circle.
Why do you think this asymmetry exists?
And
Why
because
aren't all the muscles at the same distance from the limbus?
each recti muscle are arranged, like medial rectus is 5.5 mm from the limbus. Then
Yeah,
because of different its insertion from the limbus, there is this asymmetry.
that's what I'm asking. Why did nature make that asymmetry? What is the purpose of that? Why not all the muscles from the same distance from the limbus?
Anatomical and surgical.
Yeah, yeah. Have you ever thought about it? Can you tell me what is the orientation of your orbit? What is the
Quadrangular.
orientation of the orbital walls? The medial walls of the orbit are parallel to each other. Lateral
Yes.
walls, lateral wall,
Yes, 60 degree to, like, between the medial and the lateral wall is a 45-degree angle.
yeah. So that was a clue actually. Can you pick that up? Okay, tell me what is the difference between the orientation of your eye and a lower animal, say a rabbit?
And we have a pyramidal quadrangle or
Orientation of your eye and a lower animal, like say cow, deer.
Meaning,
Hmm?
Shivani, where do you look at and where the animals look with both the eyes?
they look straight, whereas animals look
Yeah,
Yes.
they are
both
right.
sides.
So that is because the orbit is oriented like that.
Okay.
So this asymmetry does what is it pulls your eye so that both the eyes are looking in the to forwards.
Okay.
Understood? Because if you see a patient under GA, the natural position of rest of the eyeball will be divergence because of the shape and orientation of the orbit. Now, because of this asymmetry, the medial rectus is strongest.
Oh,
Pulls your eye towards so that you're looking straight, right? And that gives what advantage to you?
Binocular
exam.
single vision.
Binocular vision. So you have a high degree of stereopsis and binocular vision. Okay.
Yes.
I think 8:30 is done. You want to go on to the next? She's done well, ma'am. Naina
Yeah,
ma'am.
yeah, she could answer all the questions. I mean, she's
Ah.
Yeah,
See,
thanks.
just remember, Shivani, one thing, your diagnosis may be Brown syndrome or whatever, but not necessarily that the examiner is only going to ask you Browns. He may,
Yes.
anything that you mentioned in the history, like sudden onset, vision, sudden loss, anything, examiner can pick up anything from there and ask. So when you're getting the case, don't think, Arey, Browns there, so start memorizing Browns, 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 because she may not even reach up to Browns. Okay.
True. True.
and also the refraction part is important, and it has marks like whether it is wet retinoscopy or dry retinoscopy, then what agent have you used and at what meter distance you have done the retinoscopy. So everything counts for pediatric patients, atropinization and
Yeah.
yeah.
But overall basics you answered very nicely.
Yeah, and also atropine is like one of the most frequently asked drug in the Viva. So, apart from its cycloplegic action, you have to know the other actions of the therapeutic uses of atropine as well.
Yes.
Okay, so Naina ma'am, you have any comment to make?
No,
No,
she presented well. Yeah.
Yeah.
no, I'm glad that MOS is encouraging students, and this way, Shivani opened the chapter of squint and everything. To be very frank, everybody is very scared, and they run away from squint patient. So thank you, Shivani, for mentally preparing first, and then presenting.
Thank you,
Yes,
ma'am.
yeah, thank you
Good
so
job,
much. The
Shivani. Best
exam,
of luck for the exam.
Thank you,
yes,
ma'am.
And
Yeah.
thank you, examiners. You really asked simple and important questions. Very interesting discussion. I hope the students who are, online will really benefit from all these things. Thank you so much.
Many students, they don't see the live sessions, but they see the sessions afterwards.
Later on, yes.
Yeah.
And I should also, take this opportunity to thank my associate Salma.
Yeah.
When I was doing this case, she was actively assisting me, and she also takes a lot of interest in teaching Squint along with me. Thank you, Salma.
Thank you, ma'am.
Thank
Ma'am,
you.
have any comment to make? Salma, ma'am.
Thank you so much, ma'am, for organizing this webinar. Thank you, examiners, and thank you, MOS team. Thank you so much.
Okay. So we'll move on to our next case, and the next case is by Dr. Shraddha Kubde, and her mentor is Dr. Shilpa Sonar Khan. So Dr. Shraddha. Dr. Shraddha.
Yes, good evening, ma'am. I'm there.
Okay. Will you please start sharing your presentation? Dr. Shraddha?
Yes, ma'am, I'm sharing my screen.
Yeah.
Yes,
Can you make it full screen? Yeah, we can see. Can you make it full screen, please?
Yes, ma'am. Yes, good evening, ma'am. Sorry for the delay. There were some technical issues. I'm extremely sorry.
No, it's okay.
Yes. Shall I begin, ma'am?
Yeah,
Yes,
yeah,
yes.
please.
Myself, Dr. Shraddha, I'm presenting a case under the guidance of Dr. Shilpa Sunarkhan, ma'am, who is HOD in pediatric ophthalmology at our hospital, HV Desai, Pune. So, patient, a 12-year-old child, female, resident of Pune, brought by her parents to our hospital with the chief complaints of inward deviation of the left eye, which the parents noticed since the child was 4 months of old. Child was apparently all right at birth, and her parents noticed inward deviation of the left eye since the child was 4 months of old. The deviation was insidious in onset, constant in nature, and it was stable and progressive, non-progressive over the years. It was not associated with any aggravating or relieving factors. There was no history of variability in deviation during day. There was no associated double vision. Deviation was persistent even with the use of spectacles. Parents also noticed slight face turn to the left side, which was insidious in onset, and it was intermittent. Then they observed that left eye also appeared smaller sometimes, and also the child was unable to move the left eye completely to the left side. Child also noticed diminution of vision in left eye when the child was around 7 years of age, and for which she was prescribed spectacles and also was advised patching exercises, which the child was doing on irregular basis. Moving on to negative history, there was no history of any trauma, ocular or head trauma, no history of feverish or painful eye movements or abnormal eye movements, or there was no facial asymmetry or drooping of eyelids. There was no history of limb weakness or joint deformity or spine deformity. Also, no history of any systemic associations like breathlessness, fatigability, or cyanosis. No history of headache, vomiting, seizures, and loss of consciousness, and also any speech abnormalities and hearing impairment and difficulty in swallowing. Then there was no any significant past medical illness, as well as no history of any surgeries done in past. Past ocular history, history of spectacle wearing since the child was 7 years age. There was no history of any past medical or surgical ocular history. The patient was born with LSCS. It was a full-term delivery at 38 weeks of gestation. Birth weight was 2.6 kgs. There was no
prenatal or perinatal complications, no intrapartum or postpartum complications, also no history of maternal smoking or alcohol intake or radiation exposure during the pregnancy. Child has demonstrated normal physical and cognitive growth. All the developmental milestones were achieved at appropriate age. School performance is also appropriate for age. Patient is fully immunized up to date according to the National Pediatric Immunization Schedule. There was no history of consanguineous marriage in parents, no history of any similar complaints in past in family members, and no history of any chronic ocular disease in family. Patient is having mixed diet, bowel bladder habits are regular, sleep and appetite are adequate, and there was no history of any previous allergy. Moving on to the general examination, child is conscious, cooperative, and well-oriented in time, place, and person. Moderately built with appropriate nutrition, height and weight.
Doctor, I'm sorry to interrupt you, but your negative histories, your birth histories, your personal histories, and your general examination is a bit too long. Just
Okay,
come to the main thing. I don't think
I just directly come to ocular examination.
Yeah.
Yes, ma'am. Okay. So, for the right eye, unaided visual acuity was 6.6 parts, and which was improving till 6.6 with cycloplegic refraction of minus 0.5 diopters of cylinder at 180 degrees. Near vision for right eye was N6, and color vision was normal in right eye. For left eye, unaided visual acuity was CF3 meters, which was improving with minus 1.25 diopters of cylinder at 180 degrees up to 660. Near vision was N36, and we could not measure the color vision in the child because child could not read even the demo plate due to poor vision in this left eye. Then moving on to the sensory evaluation of our case, on Worthford dot test, which was performed after correcting the head posture, that was the left face turn in the child, performed at 33 centimeters and at 6 meters, and the child could appreciate 2 green, 1 red, and 1 white color dots. So suggestive there was no diplopia or suppression. Stereopsis done with TNO test, there was gross stereopsis affected. On ocular motility evaluation, head posture was straight. There was head posture. There was a slight face turn towards left side. No head tilt or chin elevation or depression. Facial symmetry was maintained and forehead was normal. Then on ocular motility evaluation, in the right eye, all the ocular movements were full, free and painless in all directions, while in left eye, adduction, elevation and depression were normal, while there was limitation of abduction in the left eye in all lateral gazes. Along with that, there was downshoot on adduction in the left eye. On the versions movement, there was underaction of the left eye in levoversion, levo elevation, and in levo depression, while in the levo abductions, the right eye movements were normal, while with dextroversion, there was narrowing of palpebral fissure and retraction of globe, with marked downshoot in the left eye in dextroversion and dextrodepression. Then on direct cover test, which was performed on covering the right eye, left eye showed esotropia, that is the left eye moved from inward to outward direction. On uncovering the right eye took up fixation again, it moved from inward to outward. On alternate cover test, there was constant deviation in the left eye. On Hirschberg corneal reflex test, which was done at 33 centimeter with a torchlight, the reflex was between, in the right eye, the reflex was at the center of cornea, while in left eye, it was between pupillary margin and the limbus and the temporal limbus. Krimsky's corneal reflex test was performed, which was done with the basin prisms, which was placed in front of the normal, that is the right eye, and the corneal light reflex in the left eye was centered at the power of 40 prisms diopter, suggestive of 40 prism diopter esotropia in the left eye. Prism cover test we could not perform in the child because there was poor vision and also the child was uncooperative. Then moving on to anterior segment examination was normal in both the eyes. Also, dilated fundus evaluation was normal in both the eyes. Should I move on to the next slide, ma'am?
Yeah.
Okay.
Yeah.
So according to the above history and clinical findings, my provisional diagnosis for the case is left eye Duane retraction syndrome type 1 with left eye esotropia with downshoot with simple myopic astigmatism. Suspected etiology is aplasia or severe hypoplasia of the lateral rectus muscle in the left eye. So we advised the investigation, MRI brain and orbit to the patient to trace sixth nerve course and LR muscle integrity. And MRI scan was suggestive of left eye sixth cranial nerve hypoplasia. Then, based on the preoperative assessment and confirmed diagnosis on MRI, surgical intervention was planned for the patient. So, primary procedure we performed was left eye medial rectus recession of around 7 mm and plus modified Nishida's procedure. On postoperative day 1, there was subconjunctival hemorrhage present. Sutures are intact and conjunctiva was well opposed. Ocular alignment.
Doc, I don't want to know all this. Can you summarize your case?
Okay, so a child with came with a deviation in the left eye since which the parents noted since 4 months of age. And on examination, there was limited abduction and esotropia in primary gaze. Along with that, there was
Okay, so sorry to interrupt you. So your diagnosis is Duane syndrome. So before we start asking you the questions, I am very gently telling you that your history was too extensive. I mean, for an opthal examination, I'm more interested in the ophthalmic findings. But you wasted a lot of time talking about personal history, birth history, no his negative history. I mean, you could have also summed up saying no significant negative history of any systemic illnesses or anything. So this is just a suggestion, unless the seniors here think otherwise, because I'm not used to taking exams, but I thought that the history was too extensive and would irritate the examiner because it's not relevant to our case at all.
Okay, ma'am.
Yeah, I would like to make the same point as well. Especially some negative history like painful eye movements and all was totally irrelevant.
Yes, ma'am. Okay.
Can you
Yeah.
please stop sharing your presentation?
Yes, ma'am.
That we can discuss.
Okay. Should I start asking the first question?
Yeah.
You mentioned that the vision in the left eye is very poor, right? It was only
If you
finger
can click on the
counting.
presentation, please.
Yeah. Please stop your sharing your presentation. Stop share. That's fine.
Doc, you mentioned that that the vision in the left eye was poor, which means that he was amblyopic in the left eye. Then would you want to do an uncover test in such a patient? Or an alternate cover test? Why would you want to mention that?
Ma'am, on
I think she has just picked the case with the squint history and examination.
No, see, when the patient has
See,
poor
and the
vision, now,
patient has such poor vision. He is densely amblyopic already. Would you do the birth 4-dot test and all actually?
yeah, that's what.
You wouldn't actually do a sensory evaluation when there is dense amblyopia already.
yes,
Because what madam is trying to say, no, is that when the vision is poor, when the eye is amblyopic, it's common sense to understand that this patient is not going to have any stereopsis and neither is doing the word spot or test of any clinical use to you. Okay.
yes,
Shraddha,
And
can
the
you keep your video on?
yes, ma'am.
The examiners are asking you questions, so you should keep your video on. Okay, if you're not able to do it, then it's okay. Answer the questions.
You also mentioned that the patient was amblyopic, but at the same time, you mentioned that the patient has a face turn. So these two things don't correlate
Don't go.
because the very fact that the patient has head turn means that he's trying to get some binocular vision. So if he had a head turn, then why is he amblyopic? And Duane syndrome very rarely are amblyopic. Do you have an
Okay,
answer
you
for
can
that?
still explain. Okay, you can still explain, tell us what could be the cause for poor vision in the left eye.
Ma'am, because it is since
If
it is
if you want to say that it's not dense amblyopia, it's something else.
no, ma'am, it is first because of simple myopic astigmatism in the patient. And secondly, since it is the patient is having deviation since birth, so that led to suppression in the same eye, quite, and
I
led
think you didn't understand my question.
Ma'am is asking that if the patient, what are the other causes? Like, suppose if this patient had Duane syndrome, he has poor vision, then what do you think the poor vision is because of? What are the other types of amblyopia? What are the
there
other
can
causes of amblyopia?
be sensory amblyopia, which is a sensory deprivation amblyopia, which can be due
So, Shraddha, can you start your camera, please?
sir, actually, I'm not able to on the video.
Okay, no problem. You go. Let's go ahead.
Yeah.
What are the types of amblyopia?
There can be sensory amblyopia, which is due to either due to congenital cataract or corneal opacity because of diminution of vision in the same eye. So that eye becomes amblyopic. Second, it can be because of anisometropic amblyopia, when the same eye has higher refractive error as compared to the other eye. So that led to amblyopia in the same eye. Then because of strabismic
Patients
amblyopia,
with Duane's are prone to which type of amblyopia?
ma'am, there is
It's not strabismic because, like ma'am said, they have a face turn, so it is usually not strabismic.
mostly
What
they have,
other kind of amblyopia are they prone to?
it can be refractive error because of anisometropia in the Duane's.
Mm, They generally tend to have high degrees of astigmatism. So there can be a meridional amblyopia if refractive error has been ignored since birth.
Yes, ma'am.
What is morning disk syndrome?
Morning disc syndrome.
Morning glory disk. Yeah.
Glory disc syndrome is one of the one of the associated syndrome along with DRS.
So that could be the cause of poor vision.
Yes, ma'am.
Yeah. What else?
Then another syndromic associations with the DRS.
One more thing which I wanted to point out was,
How do I
again, you
mute
said there is
myself?
face turn since so many years. Do you expect the patient not to have facial asymmetry?
How was the face turn, Shraddha?
Face turn, ma'am, it was towards the same side of the eye which was affected, towards the left side.
Okay.
Was it very significant? How much was the face turn?
It was not very significant. There was a slight face turn which the parents noticed.
Okay, what kind of facial asymmetry do you expect and where?
Ma'am, there can be cleft lip or cleft palate or coloboma of eyelids or etc. in syndromic associations. Then
Okay. So what happens to the face when there is a face turn over time? Hmm?
the pulse.
It will be mid-facial asymmetry, no? The growth of the facial bones on the side of the face turn will be affected. They will be shortened. So in fact, that is the indication for you to intervene in a patient with DRS early and
Yes.
not to wait too long.
Yes.
What was the indication for MRI in this patient?
Ma'am, since it was congenital in onset and to confirm our diagnosis, whether it is because of sixth nerve palsy or because of Duane's retraction syndrome, we performed MRI in the patient. And on MRI, we found there was hypoplasia of the abducens nerve nucleus, which was more in favor of Duane retraction syndrome.
But doctor, does the management change?
No, ma'am. Management doesn't change.
So I think routine MRI might not be required.
Okay.
So am I audible?
Yes, ma'am.
Dr.
Yeah,
Shraddha, are you
now
there?
You're audible.
Yeah, so what I was asking you is that first question is why did
Your
you
network is not
pass away?
consistent, ma'am.
But whatever you found on MRI, was it relevant? Sorry, will the management change based on your MRI finding? Can you hear me?
Yes, ma'am. Yes, ma'am. I can hear you.
Will the management change?
No, ma'am. We would still have performed the same surgeries.
Acha. What is the right age to perform the surgery if the patient is amblyopic like this? He has only finger counting vision. So if you do the surgery now, what are the sequelae that can happen? Will it remain corrected for a long time? Will it come back? What will happen? Would you like to do the surgery now, or would you like to do it at a later age? Because this is purely a cosmetic surgery now.
Yes, ma'am.
So what happens if the patient has just finger counting vision now? Then what happens if you do the squint surgery at this age? Would it come back, the squint?
Very sure.
Okay, no worries. Dr. Bhatt, you have any questions?
I think I've made my points. Yeah.
My gentle suggestion to you is, your history was too extensive with a lot of know this, know that, this, that. But if there was, when you're presenting the case now, it should be very short and sweet. Because sometimes what happens is that when you talk of so many negative things, a Khadus examiner will start talking about why did you do this, why did you ask this and all. It will not reach your case only.
Yes, ma'am.
No, ma'am, actually,
So,
she's a DNB resident. So in
No,
DNB, I think they need a thorough negative history.
yeah, but negative history should be relevant to the case, right? What is the point of asking so many negative things, so many
Yeah.
things about birth history,
Yeah,
etc.?
that is right.
I
That
mean,
is right.
but I don't know. I'm not an examiner, so I don't know
The
what the right
last time
thing.
when there was the MOS PG webinar, the last examinees were, pointing out more, on history taking. It should be
Acha.
detailed. Yeah, because last time when I attended the MOS PG webinar, everyone was examiners, because this is not about showing your surgical skills and what surgery has been done and all. For PG students, it is more about history taking and
And
No,
for
I
MS
agree,
exam,
but I think that her
Yes.
history was very irrelevant and
yes.
just too
So,
much of.
since DRS is associated with other syndromes, I asked her you should take negative history, because if someone
Acha.
asks you what are the other systemic associations, you should be able to tell. Probably she should have just said in one sentence there was no systemic association.
Correct.
Instead,
Correct. So
yeah.
on
what is
reading
No,
all
the
so that
Shraddha, what
what
is the
I
common
think,
syndrome?
is the student should be able to gauge the mood of the examiner as she's talking. Okay, that much little they have to understand.
and
So
yeah.
when she's telling all this, if the examiner is receptive, then it is okay. So I think that is a small flaw in this format. We
Yeah.
should keep talking from the beginning, not only in the end. So then she will know the mood of the examiner. And then if the examiner is getting irritated, she has to cut down short.
No, ma'am, and actually in MS exam, there are 50 marks for case presentation. So out of those 50 marks, there are certain marks for history, certain marks for examination, and then diagnosis, and then question answer. So, but yeah, she should be
Yeah.
relevant to the case. Yeah, that's a
And
take.
also we divide as long case, short case, and fundus case like that.
Ma'am,
Actually,
no more.
in Karnataka.
Okay.
Karnataka, we are still following that.
Yeah, in Maharashtra, ma'am, we have 50 marks per case now.
No, everything
Oh.
agreed, Dr. Archana, but this was, like you said, the
Yes.
history has to be relevant to the case.
Yes.
Okay,
I agree,
forget, no worries, Shraddha, it's a good learning point. Nobody's criticizing you or anything, so don't worry about it, okay?
Yeah.
Tell me something. You mentioned about the TNO random dot test, now. Which are the stereopsis tests you know of?
Ma'am, there is one titmus fly test.
Very
Then,
good.
in which we have to make the child wear Polaroid glasses.
I didn't ask you the description of the test. I asked you which other tests you know of. So just name them.
Yes, ma'am. Second is TNO test.
Okay. What else? Have you heard of Lang's test?
Then there is one more Frisbee test. Then
Can you
Okay, how-
tell a simple
Stereo-
clinical test how you can assess stereopsis? I don't have all these fancy charts.
and we can ask the patient to hold two pencils in both the hands, and then can ask the patient to join the tips of both the pencils to each other.
Yes,
And
yes,
he's
good.
closing.
How do you differentiate a Duane syndrome from a lateral rectus palsy?
Clinically, we can differentiate it. In lateral rectus palsy, there won't be any globe retraction or shortening of palpebral fissure. Also on MRI, in the lateral rectus palsy, in DRS, we see hypogenesis or aplegia of the sixth nerve nucleus. And also on force duction test and force generation test, we can differentiate from DRS and sixth nerve palsy. FDT, force duction test, is positive in DRS while it is negative in sixth nerve palsy.
Okay. What is the other name for Duane syndrome?
It is Stills-Turk syndrome, also congenital cranial dysinnervation disorders. It's classified under CCDS.
So what are the two classifications of Duane syndrome?
There is one given by Huber, Huber's classification, in which he
That is based on?
That is based on EMG findings, electromyographic.
Okay. And the other one?
And the other one is based on the appearance of the eye in the primary gaze, whether isotropic, exotropic, or whether it is orthotropic.
Okay.
What are the other restrictive muscle disorders in the eye?
Other than that, there can be thyroid-associated orbitopathy, or followed by orbital trauma. There can be orbital wall fracture with entrapment of some muscles.
Yes.
Brown syndrome.
Okay.
Then idiopathic orbital inflammatory syndrome, orbital myositis can also.
Okay.
You said this patient had spectacles, no?
Yes, ma'am.
What refractive error did they have?
She had myopic error, simple myopic astigmatic. Sorry, she had myopic astigmatism.
How much of myopia?
There was minus 1.25 diopter, so power at 180 degrees.
Okay. Okay. Then, madam, what else you want to ask?
Yeah. I think we can wind up.
Yeah, Dr. Shilpa, your comments, please.
Yeah, so thank you, Shraddha, for presenting this case, and I would like to thank MOS and Dr. Himalini Madam and Dr. Sunaina Bhatt for guiding Shraddha. And this case, of course, as you said, that MRI is routinely not required, but this patient did not have much significant narrowing of palpebral fissure and no retraction of globe. That was the only reason.
Yeah, and I noticed that on the 9 gates.
yes.
Yeah.
But
Yeah.
that is what Shraddha should have mentioned, no? When
Yeah, I had
somebody asked that, why is the
Yeah.
MRI being done?
Yes. So that was the only reason we checked the palpebral fissure height in lateral gazes, and there was 2 mm difference in the palpebral fissure height and mild narrowing of palpebral fissure. That was the only, because usually head posture, -4 limitation, all these are not very typical of Duane's without significant no
Okay.
retraction.
How was the muscle on table?
Muscle was not very lax, it was tight. So that's why I went ahead with the Nishida's procedure.
Okay.
And so that was the the dilemma in diagnosis. That's why I went ahead with the MRI, MRI to just rule out if there is an acquired LR palsy or something. And otherwise, usually we do not do. Of course, we don't have to do MRI for DRS. And if when the hypoplasia was confirmed, I labeled it as DRS. That should be told by the the student while presenting why MRI was done, and aptly pointed out by you guys, and that is a learning for her.
No, it's okay.
No,
It's
also, Shraddha, the learning point is that look, the child has no vision. I mean, has poor vision. He's amblyopic. Then you would only want to do a cover test. And cover test, you just said left convergent squint with poor fixation. Why would you want to do an uncover test? Are you there, Shraddha?
Yes, ma'am.
We have the Grimsky test only
No,
measurement.
you mentioned alternate cover test in your history,
Cover
and
test
you
you
mentioned
mentioned.
uncover test in your history. If the patient has poor vision, why would I want to do any of those?
Because the child had 660. Yes, she was very uncooperative, but
No, I'm asking Shraddha. I'm not asking it. That's okay. She should understand what she needs to present and what she should not, no? Because the examiner will catch you on small points like this. Duans तो बाजू में रह जाएगा. ये फिर यही पूछेगा ना examiner कि ये क्यों किया तुमने? Cover and uncover test is not indicated in this case.
Yes, ma'am.
Huh? So you have to just
No, I
sometimes you have
think
to.
one suggestion to the panel, like we should ask the examiners to speak from the beginning. I think that would have taken care of this problem.
yes, ma'am. Yes, ma'am.
Yeah, for future sessions, you can
Yes.
just instruct the examiner to like interrupt the student anytime they want. So
Yes.
because generally that's how we conduct the exam.
Okay. Okay. Yes, ma'am.
Anyway, thank you, ma'am, for this opportunity.
Yeah. So
Thank you to Dr. Piyush as well for having me here.
yeah.
Thank you, everyone.
On behalf of Maharashtra Ophthalmic Society and Dr. Piyush, unfortunately, is not there today. But on behalf of Dr. Piyush Bansal, Maharashtra Ophthalmic Society, I would like to thank Dr. Sunaina Bhatt ma'am and Dr. Hemalini Samant ma'am for asking wonderful questions to both the students. And both the students, Dr. Shivani and Shraddha, they did a wonderful job. I would like to thank the mentors, Dr. Naina ma'am, Dr. Salma ma'am, and Dr. Shilpa for mentoring the students. And I would like to thank Sunil ji for the technical support. So thank you so much, everyone, and see you at the next webinar. Thank you.
Thank you.
Thank you for the
Bye-bye.
opportunity. Thank
Thank
you,
you.
wonderful
Bye-bye.
examiners. You made it
Thank you.
interesting. Thank you so
Thank
much.
you, Malini ma'am.
Thank you.
Thank you, Surena ma'am.
Thank you.
Thank you, Archana ma'am.
Thank you. Thank you, everyone.
Bye.
Have a good night.
Yeah.
Yeah,
Good
good night.
night. Bye. Bye.